Hello, this is Sharon Gould. Today we will delve into learning about what vulnerabilities HIV and AIDS patients have and how they affect their access to healthcare. Within American communities, there are special populations that face challenges in obtaining access to quality healthcare. This may be due to physical, psychological, and/or social health of certain populations. Those diagnosed with HIV or AIDS may be affected by varying conditions related to socioeconomic factors. But the fact is, there are 1.2 million people living with HIV in the U.S. as of 2012. Such a large population carrying such a devastating disease requires attention. So who is at risk? Where you live in the United States is a noteworthy factor regarding prevalence of new AIDS diagnoses. In 2014, the southern states accounted for 52% of all new AIDS diagnoses in the U.S. The Northeast, West, and Midwest states were 18, 17, and 13% respectively. Gay and bisexual men accounted for 83% of HIV diagnoses among men, particularly for Black and African American gay and bisexual men. Furthermore, the spread of HIV in rural communities has been on the rise, mostly among young, non-white females who have contracted the virus through heterosexual contact. The CDC conducted a study in economically disadvantaged zones in urban areas across 25 cities. They reported information regarding employment status, education level attained, race, age, home ownership status, and income level. There was a strong inverse relationship between low income level, at or below the poverty line, and likelihood of HIV infection, unemployment, and low education level. According to Reilich, only 7 out of 100 people on a global scale have some university education. It is not so far removed that a lack of education could contribute to high transmission rates. There is an option available for HIV patients: highly active antiretroviral therapy. This is a combination drug therapy given to patients for AIDS and HIV therapy. This is an expensive option for patients to lower their viral load, and from an ecological perspective, makes the treatment unavailable to those from lower income families. Once entering HIV care, the patient is expected to live on average about 24.2 years, and depending on medication selection, can anywhere between $385,000 to $619,000 over the span of a lifetime. Women face about a 25% chance of passing on HIV to their child during childbirth without drug intervention. With treatment during pregnancy, it is possible to lower transmission rates down to 11%. From birth, these children may face discrimination from healthcare providers who refuse to treat them. As mentioned before, beyond discrimination, a lifetime of treatments are costly. Taking insurance providers who are hesitant to take on consumers with pre-existing conditions and combining that with the general socioeconomic background that many of these new patients are coming from, it may hinder access of care to these individuals. So what risks do they face? One of the main risks is opportunistic infections. As AIDS is a disease that affects the person's immune system, unfortunately that means it only makes people more prone to other infections. Some respiratory infections, such as tuberculosis or pneumonia, are often contracted as a result of a weakened immune system, as well as cervical or lymphoma cancer. On a worldwide scale, if we are to take into account Reilich's statistics of only 87 out of 100 people who have access to clean water, then those with AIDS worldwide will be particularly prone to more diseases. As these patients contract other diseases and become more ill, they require more medical intervention. They may need to take time off from work or leave their jobs due to disability. They may begin to rely on social welfare programs such as Social Security, disability, and supplemental security income. Government-funded programs such as Medicare or Medicaid may have to become more responsible for paying for these healthcare services. So what total outcomes can we expect? Medicaid covers a large portion of people with HIV, somewhere between 200,000 to 240,000 people. For the entire cost of medical care for an HIV-positive person, about 72% of the cost is for antiviral medication, 13% is for inpatient care, 9% is for outpatient care, and 5% is for other HIV-related care. There is a strong tendency to fund secondary care for individuals following a diagnosis. For there to be a beneficial impact at the population level regarding lowering transmissions and diagnoses, there needs to be a shift from secondary care to preventative care. And now it's time to hear from you. First, one of the greater concerns with newly diagnosed HIV patients is appropriate provider training for counseling. What is the best way to approach this? Furthermore, how would an approach to poor urban areas which hold high HIV rates differ from approaches to rural areas? And finally, with the 2015 Supreme Court decision of the Obergefell v. Hodges declaring same-sex legal in all 50 states, do you feel there will be a shift in attitudes from healthcare providers in their treatments to gay and bisexual patients who are newly diagnosed with HIV? Thank you.